The other regulatory mechanism are three of them. One is a chemoreceptors, another one is ADH, and the third one is called cardiopulmonary baroreceptors. Let's start with chemoreceptors. Let me first make sure I understand. These chemoreceptors that we are talking about mainly is responsible for your breathing. So we're going to talk about this one in the respiratory system. But however, has also some effect on your blood pressure. Let me explain to you how it works. Let's say here is your brain, this side is your brain, and this one is your blood. Remember, between your blood and brain, we have blood-brain barrier. Brain, or specifically your medulla of the brain, has a center for breathing. And this center is very sensitive to low pH. As soon as pH drops, this center is going to send signal and make you to breathe. What is going to happen if I hold my breath? Well, if I hold my breath, inside your blood, my CO2 is going to increase. As soon as my CO2 is going to increase, CO2 is going to pass this blood-brain barrier, is going to come to medulla, and inside the medulla, CO2 is going to add to the water and is going to create H2CO3, which is the acid, and is going to break down and increase H and decrease my pH. As soon as my pH down, this guy is going to become so agitated and make you to breathe more. And that's how you have to breathe. You cannot hold your breath indefinitely because your CO2 is going to build up. If for some reason blood flow to the brain slows down, let's say less blood is going to come to the brain. Why? Maybe blood pressure drops. If blood pressure drops, less blood is going to come to the brain, yes? When less blood comes to the brain, then brain is going to accumulate what? CO2. And when brain is going to accumulate CO2, something is going to happen, and that is when CO2 goes up, this center is going to become agitated, and as part of this agitation is going to increase your sympathetic activity. Remember, sympathetic is going to open up your respiratory system to get more air in. But also sympathetic is going to squeeze the vessels. When sympathetic activity goes up, sympathetic is going to squeeze the vessels that goes to the kidney, squeeze the vessel that goes to your skeletal muscle, squeeze the vessel that goes to your GI, squeeze the vessels that goes to your skin to shift this blood toward your brain, because brain needs blood. You squeeze the vessels of some specific arteries. As a result, blood is not going to go to GI system, blood is not going to go to the skin, blood is not going to go to the muscle, blood is going to get shifted to the brain. Sometimes this effect of sympathetic is so impressive that blood pressure is going to go so high to be even life-threatening. But that's how your body is trying to protect your brain to get more blood. So sympathetic is going to open up the respiratory system, so you're going to breathe more, but sympathetic also is going to squeeze blood vessels to shift blood to the brain. Now, this center is called central chemoreceptor because it's in the brain, central, and detects CO2, chemical. However, we have another chemoreceptor that is not in the brain, is in the peripheral. In fact, is in the aorta and carotid artery again. Very close to what we saw a few minutes ago for baroreceptor reflex. Remember this picture? Do you see here it says carotid sinus, and here is supposed to be aortic sinus? Next to this one, there's another structure. It's called carotid body and aortic body. So they are very close to each other. This is for baroreceptor reflex, but there's another center here that's called carotid body. And that carotid body is going to detect the amount of oxygen in the blood. Now, imagine that we have the receptor here that detects how much oxygen you have inside the blood. Let's say this is your aortic arch, and this is your carotid artery. There's a receptor here, and there's a receptor here. This one is called carotid body, and this one is called aortic body. These two, they detect oxygen. In the brain, medulla is going to detect CO2. This one is going to detect oxygen. And normal oxygen in the blood is around 100 millimeter of mercury. If the pressure of the oxygen drops around 50 or 60 millimeter of mercury, then this guy becomes very agitated. These are backup compared to medulla. Medulla is the main center for breathing. This is a backup system. When your oxygen drops to 50 or 60, then these two, they're going to send information to the medulla and tell the medulla, hey, what you're doing, you have to make this person to breathe. As part of this effort, we said sympathetic is going to become what? Activated. Sympathetic is going to squeeze your artery and vein. As a result, your blood pressure is going to also go up. So far we said we have two chemoreceptors. They are inside the medulla, it's called central. They are inside the carotid artery or aortic body, and that is called peripheral. Both of them are responsible mainly for breathing. However, as part of this effort to make you breathe, sympathetic becomes activated, and sympathetic also can squeeze artery and increase your blood pressure. The next one, which we explained briefly a few minutes ago, is about ADH. ADH has two receptors. One is called V1 receptor, one is called V2 receptor. This picture shows V2 receptor. V2 receptors can be found in the wall of collecting duct. This cell is the cells of the collecting duct. ADH, or also is called AVP. Remember, there's another name for that. Arginine vasopressin. When ADH or AVP sits on the V2 receptor, this receptor is attached to GS protein. GS protein becomes active, is going to activate adenine cyclase. As a result, the cyclic AMP inside the cell is going to go up. When cyclic AMP goes up, protein kinase A becomes active, and protein kinase A is going to insert aquaporin channel here. Water is going to come this way and it's going to get inside the channel, it's going to get out. So therefore you pee less. So the function of the ADH is inserting these aquaporin channels in the wall of your collecting duct. As a result, water can come out. If you don't have ADH, you don't have these channels, and as a result, water is going to stay inside the collecting duct and you pee more. That's why we call it antidiuretic hormone. Antidiuretic hormone is going to be against urination. That's one function for antidiuretic hormone. But you remember from your endocrine system that antidiuretic hormone has another receptor, and that is called V1 receptor. V1 receptor is found on blood vessels. When AVP sits on V1 receptor, this receptor is attached to GQ receptor. When GQ becomes activated, it's going to activate phospholipase C. Phospholipase C is going to break down PIP2, if you remember, and PIP2 is going to break down to IP3 and DAG. And do you remember IP3 is going to release calcium? By releasing calcium, your smooth muscle of this vessel is going to go to contraction, so vessel is going to constrict. As a result, blood pressure is going to go up. Don't worry about the rest of this one. I want you only focus on this part. DAG is going to have other function here that we are not going to discuss, but what you need to know is when the ADH is going to sit on the V1 receptor, it's going to release calcium and it's going to cause vasoconstriction. So far we said to regulate arterial pressure, we can use baroreceptor reflex, or we can use renin-angiotensin-aldosterone system. We said besides these two, we have other centers to regulate blood pressure. We said we have chemoreceptors. They mainly deal with breathing, but also they're going to activate sympathetic, and as a result, your vessel is going to go to constriction. ADH also can regulate your blood pressure because ADH has two receptors, V1 and V2. V2 is going to decrease the amount of urine, conserve water, and V1 is going to squeeze the blood vessels, and as a result, blood pressure is going to go up. And finally, we have another mechanism to control our blood pressure, and that is through baroreceptors that they are found inside the vein, atria, or pulmonary artery. Do you remember these are the receptors in the wall of the artery? We have some receptors, they are not in the wall of artery, they are in the wall of the atrium, they are in the wall of pulmonary artery, and they are in the wall of veins. That means they detect lower pressure. Remember, pressure inside the artery is high, pressure inside the vein is low. So we say those are baroreceptors for low pressure. These two are baroreceptor for high pressure. These baroreceptors, or low pressure baroreceptors, they respond to fullness of the vein. Let's say this is a vein. Remember, inside the vein, the pressure is low. When you have blood, this blood is going to put pressure against the vein. If the volume decreases, then the amount of force that you apply to the wall, of course, is going to drop. So therefore, I would say the low pressure baroreceptors detect the fullness of the vessel. Fullness. In other words, they detect how much blood we have inside the vein. As a result, they deal with volume. There are a few ways to play with water and sodium. Let's say this is your heart. If the amount of blood inside the right side goes up, then they're going to put more pressure against the wall of the atrium. As soon as they're going to put more pressure inside the right atrium understand, hey, I have too much fluid. So as a result, this right atrium is going to release something called atrial natriuretic peptide, ANP. This ANP that is released from the right atrium is going to cause vasodilation. Vasodilation, yes, is going to open up the vessels, your blood pressure is going to drop. But more importantly, this vasodilation is going to happen inside the kidney. Do you remember this slide? We said this is afferent arterial. Blood is going to come this way, it's going to come inside this capillary, and it's going to filter inside this nephron, we said. I'm sure you realize that all the blood that comes here is not going to filter. Some is going to go through this one. This vessel here is called efferent arterial. So we have afferent arterial, we have a capillary, which is called glomerulus, and then we have efferent arterial. ANP, what it's going to do is going to open up the afferent arterial, and it's going to close efferent arterial. In other words, more blood comes in, and less blood is going to leave. The pressure inside the glomerulus goes up, and I'm going to filter more. The more you filter inside this nephron, that means you're going to create more urine. So ANP is going to make you to lose sodium and water by making you to filter more. How ANP is going to do that? By opening afferent arterial and by closing efferent arterial. There's another important thing here is this. If I open afferent arterial and I close efferent arterial, I'm increasing the pressure not only inside the glomerulus but also inside the afferent arterial. My afferent arterial is going to say, maybe the blood pressure is going up. So as a result, my afferent arterial is going to stop releasing renin as well. Stop the release of renin is going to decrease angiotensin 2, and decreasing angiotensin 2, that means you are not going to absorb sodium, you are not going to absorb water either. In other words, you're going to lose sodium and water inside your urine. So therefore, as a result of increasing ANP, you're going to go to the kidney and make the kidney to dump sodium and water. As a result, your blood pressure is going to go down. As you can see, the receptor that you have in the wall of this atrium, by releasing ANP, is going to make you, the blood pressure goes down because it's going to make you to lose water and sodium. Also, when the pressure inside the right atrium goes up, that is going to send signal to hypothalamus and tell the hypothalamus that pressure is up, too much fluid. Hypothalamus, as a result, is going to stop releasing antidiuretic hormone. When antidiuretic hormone is going to go away, you are not going to keep the fluid. As a result, you're going to dump lots of water inside the urine, and your blood pressure is going to go down. As a matter of fact, the same is true for receptors in the wall of veins and also receptor in the wall of pulmonary artery. Also, I have to mention that when the receptors in the wall of vein or atrium or pulmonary artery become activated, they're going to inhibit sympathetic activity. By inhibiting sympathetic activity, you're going to create, again, vasodilation. So vasodilation is going to make you to release renin, and of course, you're going to lose more water. And finally, these receptors in the wall of atrium, vein, or pulmonary artery has a very important function, and that is they're going to send information to the nucleus solitarius through cranial nerve number 10. Remember, in the case of high pressure vasoreceptor, the cranial 9 and 10, they're going to send information to nucleus solitarius first, and as a result, they're going to change my heart rate. If the pressure here is up, the sympathetic is going to slow down and my heart rate is going to go down. Do you remember that? So as a result of high blood pressure, I'm going to slow down my heart rate, because by slowing down the heart rate, cardiac output is going to go down, then cardiac output is going to go, and blood pressure is going to go down also. However, if this information comes from low pressure receptor, not high pressure, but low pressure, if it comes from the vein, pulmonary artery, or atria, this information is going to come to medulla, to nucleus solitarius, but surprisingly increase my heart rate. That doesn't make sense. If the pressure is up and you increase the heart rate, then you expect that your heart rate goes up, your cardiac output is going to go up, and your blood pressure is going to go even higher. So why does it do that? Well, the answer is, now listen to this one. When heart rate goes up and cardiac output goes up, this cardiac output brings more blood to the kidney, the pressure inside the glomerulus goes up, and I'm going to filter more. The more you filter inside this nephron, that means you're going to create more urine. And if brings more blood to the kidney, it's going to stop the release of renin, and as a result decrease the angiotensin II. In the case of low pressure receptors, they send information to nucleus solitarius, but surprisingly they increase heart rate to increase cardiac output to bring more blood to the kidney and make the kidney to lose more water and sodium. So I hope you understood this one and realize the difference between high pressure and low pressure.